Get the treatment and get the hell out of there.
Right.
You know, they don't want to be part of a study. They don't want to get hooked up to equipment. But you do studies where you recruit people, and you know, that's where that stuff happens. Okay, enough of that. Let's go back to the data. So, back to the PTSD work. You know, again, as I mentioned, you have to have data. You got to do science, and this is where, in our field, you know, having a good education, understanding research, and understanding the value of it makes you very valuable in this field if you decide you want to work in advanced technology or VR simulation. So anyway, just a quick walkthrough. First clinical trial. First 20 treatment completers, 16 no longer met PTSD criteria. That's a drop in PTSD at the end of treatment and continued at 3-month follow-up. Once you get people kind of right at the end of treatment, they start living their lives more fully and show continued benefits, yes.
What's PCO?
PCO is a PTSD checklist, self-report symptom checklist, a standard screening measure.
And is 17 high or 17 is like baseline or
17 is the lowest score you
lowest?
can get.
Okay.
And this is a finer point. That's the 16 that no longer met PTSD criteria. So that's your individual data points, and the 4 that did not benefit from the treatment. Follow-up study up at Fort Lewis, strong effect size, good clinical outcomes there. A study recently done, published in 2017, where it was intensive treatment. You bring people in for 3 weeks. They come to Orlando, they get a motel room right by the center, and every morning they do the VR exposure. In the afternoon, they do the traditional psychosocial stuff, anger management, maybe substance abuse, all individualized. This is unheard of effect size, 2.06. I mean, that's dramatic. I'm glad I didn't collect the data because people would think I was fudging the data to support my own development. She did it, Deborah Vidal. And what it shows is that maybe the traditional idea of once a week over 10 weeks, maybe that's not the way to go. Maybe you got to hit it hard like cancer. You know, nobody wants to do chemo, but you got to do it. You got to hit it hard. And maybe that's what we're seeing here, a compressed period of time, really digging in. There's a motivational confound here, of course. You know, anybody willing to go to Orlando and live there for 3 weeks has got to be motivated to get better. But I don't know if anybody's been to Orlando, the Cratchit Kingdom, you know, all that. It's a crazy place. Another study at Emory University showing at post-treatment significant gains, 6-month follow-up, continued 1-year follow-up. And in this study, we had the luxury of capturing psychophysiological data. Yes. So we showed changes in physiological reactivity, so going beyond self-report. We also found cortisol reactivity drawn from the blood going down. Cortisol is a stress hormone.
That's awesome.
So expanding the research in that way. The Military Sexual Trauma Project, this one required us to take like the mountain outpost and add showers and latrines and barracks and stuff. But we found out that most sexual trauma in the military is not happening in the trenches of Afghanistan. It's happening at Bates Motel or you know, other civilian places around military bases. Have a perpetrator that follows you around like the Terminator. And its character can be changed up. It's never going to be an exact replica of the person, but we can make it kind of close enough. And we don't always use it. Some therapists think it's too creepy, but that character can pop up wherever you are or follow you around depending on it. Well, anyway, here's the data from the first trial. And whenever we do these things, we start with a small study to make sure, first off, safety and feasibility. We're not hurting anybody. And as I said before, you know, when I talk about this at first, people are like aghast, you know, oh, you're creating virtual sexual assaults now. You know, as I said in the slide, you saw more Hitchcock than Hurt Locker. Hitchcock was a guy that did suspense movies and all that, as opposed to Hurt Locker, where it's about explosions, like with the combat related stuff. In this case, you're creating the context and the setting in which these kind of things have happened and reported to happen. And that's the data from the initial study. 15 people recruited, 3 dropped out before treatment. They went for the assessment interview and then never came back. 1 dropped out halfway through because she claimed that she was all good. We tried to convince her to stay because that's commonly people get this euphoria when they finally get over a hump, and it's like, okay, I'm good now. But you gotta spend a little more time really processing it. Anyway, of the 11, that's the data. That's being published in Journal of Anxiety Disorders now. It just got accepted.
So what
It'll be the
happens-
first study done in an immersive VR environment with sexual trauma.
So what does the victim of the
Trauma
assault, what are they actually doing?
What they're doing is in all exposure therapy, it's not passive. We're not just putting people in and letting them look around. They're sitting there. If you go back to the traditional form where it's imagination alone, they're sitting in a chair in the safety of the clinician's office, Therapeutic Alliance, and the therapist will say, okay, now you were telling me about this event that happened. I want you to close your eyes and imagine it happening and narrate as if it's happening right now. And sometimes, you know, the first pass, you'll see completely devoid of emotion because that's what they're trying to fight off. You'll hear a story like, I'm walking out of a bar and heading to my car, and a guy tackled me and assaulted me in my car. End of the story. Wow. Okay, the therapist said, okay, tell me a little bit more about what you were doing before you walked out to your car. You know, what was your activity? You know, and start to pull out. And what you see is over time, as you're in imagination or in the VR, you see that all of a sudden the emotion starts to come out. And it's hard medicine for a hard problem. I mean, you know, basically therapists don't like to make their patients feel anxious. That's the job here, to make them feel that anxiety, but they're in a safe place and nothing bad happens. Still a bad memory, but there's a difference between having bad memories and having PTSD. PTSD is like, think of the worst thing that ever happened to you in your life and how bad you felt when it happened or the day after. And imagine that feeling doesn't go away. Imagine 6 months down the road, you're still feeling that horrible feeling. That's what we're trying to fight. And that horrible feeling is what drives PTSD and makes people kind of enclose their world and become emotionally numb. And it comes out in nightmares and flashbacks to repress stuff. And you avoid going to places that have any whiff of what you were traumatized by. And when you avoid something that makes you feel anxious, you get a temporary sense of relief. It's like, oh, and that reinforces continued avoidance. Also, alterations in mood, emotion, in cognition, you know, this is where we see the emotional numbing. So, you know, you're trying to help the patient, again, confront and process those memories. So you go through that process for 25 to 45 minutes, depending on the patient's need and the traumatic experience and all. And then you have 20 minutes for processing afterwards, where headsets off and regular clinical stuff, talking about what it is, you know, what's going on. So that, in a nutshell, is how it goes. It's typically 10 sessions. VR comes in at session 4. You're also having people between sessions go to places that they've been avoiding or do things that they've been avoiding as homework. So you want to try to push out as much as you can activities that take it away from just in the safety of the clinician's office to the real world. You do it at a pace the patient can handle. So,
Skip, do you think?
That's that data. Let me just show one more data to answer your question. This is heart rate, just heart rate. And we have a lot of data to pick through on this. We haven't done picked through all the data, but heart rate before you go into a sexual trauma simulation, it'd be at the start of treatment, and then as you go through it, at the end of that 3-minute period, it's a structured simulation. This is at the end of treatment.
So even their baseline went down that much?
Based on, because the anticipatory anxiety about, you know, you're telling, you're not just
Right,
saying,
right,
oh, put this headset on, we're gonna make something happen.
Yeah.
You're saying, we're gonna put you in an environment that's similar to an
What you went
environment
through.
where you might, and so the anticipation, just like you're gonna get a needle now, it's like a little.
Right. It is
you
the
know?
first time, yeah.
So anticipatory anxiety down and the activation level.
Is this just two shots, one just pre and post, or did you
Pre and post.
is post?
Yeah, we
one
didn't
just
do
went
everything.
over-
Yeah,
okay.
we did pre and post.
Gotcha.
We also have all that startle response data that I showed from the previous study with some of the other psychophys, which we're just starting to
Right.
dig into, but we wanted to publish the clinical findings first
Yeah.
and then dig into that. Also, again, this falls in line with assessment, so you can put people in these simulations and measure heart rate. skin conductance, psychophys, blood cortisol. 4 studies that have been published in this area, and 2 more coming out in press. Also, pre-post fMRI brain activation studies, so before and after treatment, you're seeing changes, particularly in the amygdala. Amygdala is the fight or flight area of the brain. That's overactivated when presented with emotional stimuli in an fMRI. We're showing significant declines. Also, changes in some areas of the brain that you want to be activated, like the anterior cingulate gyrus. You want more activation as a modulator in the frontal areas for modulating limbic system reactivity. So these are all in line with the standard predictions you would expect from a brain theory of PTSD. Finally, we're not just, and this is with anything, we're not just about beating the traditional methods. Some people are going to work great with the imaginal exposure. Some people are better built for this. But we want to make options, and maybe using technology will appeal to a digital generation of service members. And in aging, unlike when I was doing aging research in the 90s, and people were saying, do you think older adults are going to use email? Do you think they're going to benefit from the internet? Are they going to adopt it? Well, that generation, that cohort is dying out. The cohort you guys are going to be building for are going to be people like me. I'm 63. I'm going to be an old fart in 10 years, So, but I'm technically, I'm part of the, I'm a digital old guy. So I want, whenever I think about building something for an aging population, I'm thinking something I'm going to want for myself when the time comes. Yeah. So, thinking about breaking down barriers to care and the relevance to the clinical or the whatever age-related cohort population that you're building for is highly relevant. And in a recent study with the service members, we did the informed consent. You can either get VR or you can get imaginal exposure. You tell them everything about both of those, but it's a study, so we're going to roll the dice and you're going to get assigned to one or the other. But if you had your choice, what would you pick? 75% picked the VR. So that's a big thing, breaking down barriers to care. So our next step, civilian translation. The sexual trauma content, we got a lot of content that's civilian oriented. We want to run a study if we can get the funding with civilian sexual trauma. We have a grant with the RAND Corporation to study LA police now. Police, firefighters, first responders are a hidden world of PTSD or of some threshold PTSD. And I'll propose something that some people might get upset about outside of here, but I believe that many police officers, from continued exposure to stress over the course of their regular occupational duties, don't have full-on PTSD, but I think a lot of times they get 2 symptoms of it. They got the hyperarousal because they've been shot at before or they've been in this situation, so hyperarousal, and they got the emotional numbing. They become maybe callous to the population they're supposed to be serving. I think emotional numbing and hyperarousal is a bad combination for pulling a trigger.
Definitely. And
so we do pre-deployment resilience training in VR for the military. I don't have time to talk about that, but we want to do that with the LA police. So when you're in the academy, you're getting exposure to things that you might face and getting tactics about how to manage your stress.